All right, hello class. My name is Tony Woolard. I'm from Middletown, Connecticut, and today I'll be presenting on exercise-induced asthma in high-level athletes. If you have any questions following my presentation, please feel free to contact me at tnwoolard, WOOLARD, at gmail.com. I want to first start off by talking a little bit about the nomenclature for EIA. So the nomenclature for EIA has actually recently changed due to the fact that it's very unclear to patients. A lot of patients were believing that this exercise is leading to asthma. And what's actually occurring is that these patients with EIA, or exercise-induced asthma, have a preceding case of asthma. And these asthma-related symptoms are later exacerbated by the exercise. One of the universal phenotypes seen in asthma is known as bronchoconstriction, which is why the name for exercise-induced asthma has recently changed to exercise-induced bronchoconstriction. Bronchoconstriction is a universal phenotype seen in all asthmatics, and what it pretty much is tightening of the musculature that surrounds the bronchioles. So I actually created a little diagram here to help you better understand. Excuse me. So here's a normal lung, and here's a lung of an individual with exercise-induced asthma. In the normal lung, you have this musculature that's surrounding, and that is not tightened, that's loose along the lining of the bronchioles. And also you have this tissue layer, which is also known as the bronchial tube lining, and then you have a thin layer of mucus that's located inside of that lining. Here, in the individual with EIA, you notice that there's a very thick tissue layer here due to high levels of inflammation. There's also higher levels of mucus due to increased secretion, and this can actually lead to a decreased ability to remove pathogens, because this mucus assists in the removal of pathogens, and you can get higher levels of respiratory infections in patients with EIA. Also, you have tightening of this musculature, also known as the bronchoconstriction. I also want to mention briefly that the severity of these symptoms can differ in different patients, and also you don't have to have every single one of these symptoms. You can have the inflammation without the constriction. You can have the inflammation and the constriction, or you can have the constriction without the inflammation. So you don't have to have every single symptom, and you certainly don't have to have the high levels of mucus secretion as well. If you can also refer to Figure 1, I provided you with a follow-along PowerPoint that pretty much provides you a diagram so that you can see it on your end what I'm talking about. But in case you don't have access to that, in Figure 1, your diagram actually shows 8 different types of asthma, but I only am discussing 3 here: exercise-induced asthma, cough variant asthma, and allergy-induced asthma. And cough variant-induced asthma, you have a lot of coughing that pretty much damages the inner lining of the airways, leads to inflammation, and then asthma. Allergies, what you'll notice is that the immune system is highly associated with the pathophysiology of asthma, even in exercise-induced asthma. And histamine is one of those immune cells, and patients with asthma take antihistamines. So allergies, high levels of allergies, can actually cause asthma. Excuse me. So if you can next refer to Figure 2, and I'll give you a little while to get to that figure. Excuse me. Basically, this figure looks at the pathophysiology for EIA. So first you have an increased demand for oxygen, and that's due to the fact that you're using up a lot of the ATP in your muscles, and they need that aerobic respiration to produce high yields of ATP. So you have an increased demand for oxygen in EIA. Then that's followed by hyperventilation and mouth breathing. This step here is known as the initiation step. There's 4 steps, and I'm going to go through them as I move down this diagram here. So the hyperventilation and mouth breathing, you have increased frequency of breathing because you're trying to get more oxygen. But the mouth breathing is also bad because of the fact that the nose has what are known as nares. And these nares help to humidify the air that goes into the lungs. The mouth does not have these nares and does not have the process of humidifying the air. So you actually end up getting this dry air that's breathed into the lungs. And that can assist in this pathophysiology of EIA. So following this dry and cold air and lung environment, you next have these two different possible mechanisms. Now this is known as the translation step. And in the translation step, you have the vagoreflex response and the mast cell mediator response. And the vagoreflex response is basically the vagal efferent nerves telling the brain that there's damage and leading to inflammation and bronchoconstriction. Here you have mast cell mediators, which are inflammatory molecules involved in the immune system that are released and lead to this increased inflammation and bronchoconstriction. There you have your bronchoconstriction, and then this last step here is known as the mediator step. And the mediator step is where you get a lot of the variation in the symptom severity for patients. So patients who have decreased pH, known as respiratory acidosis, from this high level of exercise, what you'll see is increased levels of bronchoconstriction and pretty much a more exacerbated response. Here you'll have a lessened response because the beta endorphins, they act as bronchodilators, which opposes this bronchoconstriction. And the reason I went into that whole pathophysiology is because it's very important in understanding the treatment for different patients, as well as understanding why there's poor diagnosis for EIA. So in terms of the symptoms, I mentioned how symptom severity can be dependent on different factors. Some of those factors include environmental factors. By environmental factors, I mean pollutants in dry or cold environments. Also, genetic factors such as immune responses. If you have a heightened immune response, you'll have a higher level of asthma or more exacerbated response or more exacerbated asthma-related symptoms in response to exercise. Because as we know, these immune cells are very important in the pathophysiology of EIA. And lastly, of course, exercise intensity is very important for determining EIA severity. And in fact, individuals who are athletes are found to have 5 times more prevalence of EIA. And that's due to the fact that they are more often exposed to the strenuous conditions or strenuous exercise conditions. But although there's a lot of variations in terms of the severity, the symptoms, the common symptoms, include dyspnea, which is shortness of breath, angina, which is chest tightness, decreased exercise endurance, and coughing and wheezing in response to exercise. In terms of the diagnosis, the way this works is that they use a cycle ergometer, or you can use another ergometer, but the cycle ergometer is most commonly used, and they use a spirometer as well. And they look at the FEV1 levels, and FEV1 is the amount of air that an individual can forcibly exhale in 1 second. And they look at these levels pre and post exercise, and in individuals with EIA, you expect to see at least a 10% decrease in FEV1. In fact, individuals with mild EIA have between 10 and 25% decrease, whereas individuals with moderate have been between 25 and 50, and individuals with severe have anywhere above 50% in their FEV1 decrease levels pre and post exercise. So if you can go to figure 3 for me quickly. Figure 3 just basically looks at the fact that, well, first off, I extrapolated data from various different articles, and it looks at the fact that EIA diagnosis is more prevalent in individuals who are involved in colder weather sports, or sports that are exposed to a colder environment. So what you'll see is ice skating, cross-country skiing, and figure skating all have the highest levels of, or diagnosis prevalence of EIA. And furthermore, I just want to mention as a side note, a lot of people believe that EIA severity is also dependent specifically on the weather conditions in which a person exercises. And this is not true. Although there's a high association between exercise-induced asthma prevalence and cold weather, there's not a high association between exercise-induced severity and cold weather. So I just wanted to make that note. So lastly, if you can go to figure 4, I'd like to talk about the different treatment options. So figure 4 is important because what I did was I basically broke down the treatment options based on the pathophysiology of the patient. And the treatment options are very specific based on the patient pathophysiology. I'd also like to mention as a side note that the World Anti-Doping Agency is responsible for overseeing all drug administration to athletes. And most beta agonists have actually been prohibited by the World Anti-Doping Agency because of the fact that they might have performance enhancement effects. But some of the ones that have been clinically proven to not have performance enhancement effects include salbutamol, formoterol, and salmeterol. And therefore, those are allowed to be administered to athletes. Following the administration of beta agonists, which are the primary drugs administered to an individual with EIA, you can also have anti-inflammatory drugs, which can be administered if the symptoms are not alleviated. So beta agonists, they cause bronchodilation, but they do not have any effect on inflammation. So some inflammatory drugs that you can use include the anticholinergic agents and the mast cell stabilizing agents. And what I want to mention there is the fact that those two, you'll notice that those two agents are dependent on your pathophysiology, or the way that this bronchoconstriction has been induced, and yourself as the patient. So if you have the vagal efferent response, you're going to respond to the anticholinergic agent. If you had the mast cell mediator release, which led to the inflammation, then you're going to respond to the mast cell stabilizing agent. So the pathophysiology is very important to understand if you also want to understand the treatment options for these athletes. Lastly, I just want to mention a few limitations, which include equipment access, such as access to ergometers, as well as poor diagnosis. And as I mentioned before, the poor diagnosis comes from the fact that the symptoms differ in different patients for reasons such as the different factors that they might be exposed to, like the environment, their genetics, and the amount of exercise or the severity of the exercise that they're exposed to, as well as those mediating factors at the mediating step, like that increased pH or the decreased pH and the increase in the beta endorphins. Those can also affect the overall symptoms and symptom severity in these patients. So these variations have led to a poor diagnosis for EIA in high-level athletes. Also, the lack of understanding in terms of the physiology has been very limiting because of the fact that at the translational step, although the vagal efferent response and the mast cell mediating response have been evolving as the two most likely mechanisms, these two mechanisms are not the only existing mechanisms. And this step is very poorly understood. And until we get a better understanding of that pathophysiology it's going to be difficult to understand the best treatment options for these patients. Thank you very much, and I hope you have a great day.